Okay, so today we are going to be talking about respiratory emergencies. So at this point we're going to start the deep dive into the medical topics, respiratory obviously being a fairly big piece of this, just because if you think about perfusion, right, oxygen supply to the bloodstream is pretty pertinent, right? So keep that in mind. These are topics that are going to be recurring. We'll also touch on some more specific conditions as well as treatments. So let's get started. Okay, so dyspnea, very, very common patient complaint. You'll see this in a variety of different verbiage when it comes to your actual dispatching. So shortness of breath, difficulty breathing. Dyspnea is going to be more of our description as practitioners. Okay, now dyspnea is an overarching kind of generalization diagnosis, or for lack of a better term, diagnosis, right? Just because there's several conditions that can be considered dyspnea, right? You got to think about the causes of what's making somebody have a hard time breathing. Okay, now it's not always going to be super obvious. Some things you may be very familiar with, right? But compared to when you see somebody who's sick, right? Someone who has a cold, but it could be the flu, or it could be COVID, or it could be, any number of upper respiratory type conditions. Keep that in mind, that this is an overarching description, okay? And on top of it, because a lot of them look the same and we're very limited with what we have out in the field to use for ourselves, it can be pretty hard to determine it. Right? It can be difficult to determine what is going on, which is where we have to do a really good job of reading the physical signs, reading the symptoms from the patient, and starting to make an educated guess, right? Now, not an educated guess more so as a guess, but an educated assumption about what's happening. So, like every chapter, let's start with a little A&P. So, respiratory system. It includes all the structures that contribute to our breathing. Our diaphragm, biggest muscle, at least when it comes to the actual muscle needed to breathe. The diaphragm is going to be amongst the biggest ones, right? That's the muscle that pulls down, and we'll talk a little bit more about that here soon. You have your chest wall muscles, right? Your intercostal muscles. Those are pretty important for getting that chest expansion, because if we don't have chest expansion, we can't have expanded lungs. On top of that, there's going to be accessory muscles. So your sternocleidomastoid, the big muscle that attaches the back of your head, runs along the front of your neck, and then attaches at the sternum there. You'll see that pretty frequently, or even the abdomen. Both of those muscle sets are used fairly frequently in people who are really struggling to breathe. Okay? And then last but not least, we have our nerves, right? Obviously, if we have muscles, we need those muscles to fire. We're going to need specific nerve sets to make sure we have all the muscles working in conjunction with each other so that we can start to get that chest expansion for lung expansion, get that oxygen flowing. Now, when it comes to the airway, or the respiratory system, we can break that airway down into two different parts. There's an upper and a lower airway. Okay, the upper airway consists of all the structures that lie above the vocal cords. So think your face, right? Your head. Think about where air gets into your body. So your nose and mouth, your jaw, your oral cavity, right? Around the mouth or inside the mouth. Your pharynx, your larynx, all of those are going to be considered upper airway structures, and we'll talk about those more. There should be a diagram right here. Right, so if we look at the top here, the upper airway, the split is at that larynx line. The larynx being another fancy description of your vocal cords, okay? So we have our pharynx. Now, the pharynx is one of those things that, imagine it as a tube in the back of your throat. Think about the space behind your nose that connects into your mouth, right? It doesn't sound gross, but like when people hawk loogies, right? They suck the snot and that goes from their nose straight to their mouth. That's through that pharynx space, okay? So remember, with the pharynx, we can break that down into a few different places. We have our nasopharynx behind the nose. We have the oropharynx behind the mouth, right? That space at the back of your throat. When you look at the back of your throat in the mirror, you're looking at the oropharynx, okay? And then we have the laryngopharynx, which is the space directly above the larynx there. So if you see, once again, from that tube, that structure running down, the pharynx ends right above the larynx there. All connected, all considered to be one piece with just subsets associated, okay? Now, the principal function of breathing, the reason we breathe, is so that we can get oxygen in and get carbon dioxide out. We need that gas exchange, that functional gas exchange. Remember, CO2 is our waste product. It's the primary waste product that you will be getting rid of constantly. Every time you take a breath, you're exhaling CO2, okay? Now, when we take a breath, air travels through our trachea, right, into the nose and mouth, through the pharynxes, so on and so forth, through the trachea and then into the lungs, okay? Now remember, with our lungs, we have our bronchi, the larger airways, the bronchiole is that narrows down, and then at the end of that we have the alveoli. So think of the bronchi, bronchioles, alveoli, kind of think of a tree branch, right? If you see that big stem of a tree branch coming directly off the trunk there, it starts wide and gets narrower and narrower and narrower until eventually at the end we have the seeds, right? Seeds being the productive thing for trees. Same thing for us. The bronchi, they're closely associated with that trachea, okay, as that kind of extends down into our chest cavity. And then from there, in that branching out, those will get smaller and several different limbs coming off. Those will be the bronchioles. And then at the end of the bronchioles, we have the alveoli, where, once again, that's where the actual gas exchange takes place. So you're going to exchange CO2 and oxygen, right? Deoxygenated blood will become oxygenated blood via those pulmonary veins and arteries. Now, as far as the process of breathing, now keep in mind, respiration is overarching. There's a couple of other, off the top of my head, one other type of respiration, that's cellular respiration, okay? But respiration in general is going to be an overarching process, okay? We're going to inspire and we're going to expire. Inspiration, take your breath in. Expiration, breathe your breath out, okay? When we do this process of respiration is going to be the action of exchange of oxygen into the blood, CO2 into the lungs, and out, okay? Not to be confused, that action, that exchange action is respiration. Now, when it comes to the binding of hemoglobin, oxygen to hemoglobin, that's going to be oxygenation, right? So it's kind of a big process that works pretty closely together, okay? And then all of this is happening very, very quickly. Every single time you take a breath, we have that air rapidly hitting our alveoli, okay, where we can have that gas exchange starting pretty quick. Okay, so a pretty good diagram here. You can see the capillary networks that lie around the alveoli. Now this is obviously a very zoomed in picture. These are very, very tiny structures, but these capillaries, remember we have kind of like how we have bronchi to bronchioles to alveoli, right? That narrowing. Same thing happens with our vasculature. Arteries will become arterioles. They match into the capillary, which if you're looking at this image is this kind of gray purple colored structure. From there, once the gas exchange takes place, because that happens in the capillaries, it'll start kind of entering that circulation. Now remember, this is our pulmonary circuit. And remember, arteries are always away from the heart, veins are always towards, okay? So, from the artery, we have deoxygenated blood hitting our alveoli. Our artery, arterial, capillary, that exchange, right? Getting rid of the CO2, starting to bring it back. Now, in the lungs, the venules, the capillaries will extend, venules will become veins. Those veins will then carry oxygenated blood back to the left side of our heart, the left atria in particular. You'll have a contraction of the heart, send to the left ventricle, contraction of the heart, out through the aorta to the rest of the body, where we will have an oxygen exchange still, right? We're kind of focusing pretty specifically on the respiratory side of it right now, but keep that in mind. This process happens all over the body, okay? It's not just one isolated space. Just because your lungs exchange that doesn't mean we're using it for a reason, right? We want to transfer that around. Now in the alveoli, I kind of already touched on it, but let's just touch on it again. Oxygen will pass into the capillaries, carbon dioxide will return to the lungs. Okay, now this all happens via a process called diffusion, right? Something going from an area of high concentration to an area of low concentration. Okay? Now, if you think about it, another way to think about it, or how I've always thought about it, is you take a big breath. There's a whole bunch of oxygen molecules in your alveoli. They look through the window that is our capillary, and they say, man, there is no oxygen molecules over here. I am surrounded by a ton of oxygen molecules. I don't want to be around them. So they'll jump through that capillary, right, and that'll get into the blood. While at the same time that's happening, carbon dioxide's having the same conversation, like, whew, we just got done with the body. I want to get out of here. I'm around a bunch of CO2. I want to get into that lung so that I can go back out into the fresh real world. Okay, so you'll have that exchange, and it's all because of that process of diffusion. Once again, an area of high concentration to low concentration. Now, as far as how we breathe, our brainstem is going to be what senses those CO2 levels, because fun fact, CO2 is an acid in our body. Okay, so when we breathe, we actually use what's called negative pressure breathing. And it comes from the presence of CO2, not the amount of oxygen in our body, which it makes sense if you think about it, right? Think about like your trash can. When your trash can gets full, you got to get rid of it, right? You want to get rid of that waste. It's the same kind of concept. We have so much of this that we need to get rid of it. And that's what stimulates our breath. Now, there are going to be times, and we'll talk about one in particular later, where that gets a little bit murky, and that's because of conditions, pre-existing conditions, okay? But our brainstem is the primary organ that's going to be helping to sense that CO2 to help stimulate our breathing. Because remember, our brainstem's job is necessary to life functions. Okay, with breathing, pretty necessary to life. If you're not doing that, probably not living very well. Okay, and on top of it, it helps regulate our breathing, our rate, and then our depth. Okay, helps get that. Helps us to decide how much oxygen we need, and if we're going on a run or we're sprinting, we need to take bigger, deeper breaths to get that oxygen, versus if you're just sitting there, hanging out, watching TV, doing whatever you do, right? Probably don't need to breathe that hard. So things will kind of shift depending on what we need, essentially. Now, a little bit of patho, right? So oxygen exchange can be hindered by a few different things. Conditions in the anatomy, right? Is there something like trauma that happened to the neck, to the throat, where we're unable to actually get air in? Is it going to be a disease process? We'll talk about a few of those here in a bit, but like asthma, right? They have a hard time getting the air in or getting the air back out because of air trapping, but that's going to hinder how much oxygen we have exchanging, okay? Going back to traumatic conditions, so trauma I kind of touched on, but if we even go back to conditions of the anatomy, everybody's a little different, and some people develop, their tissues develop strangely or abnormally during development, okay? And then lastly, you can have abnormalities in pulmonary vessels, right? Is there like a clot or something in there, or narrowing of vessels that's going to inhibit the amount of blood that can actually have that air exchange happening? Okay, so for us, the important things: recognize the signs and symptoms of inadequate breathing and know what to do about it. Okay. Now, end of the day, we already know oxygen is going to be one of the most commonly utilized methodologies for us to help people with breathing. Okay, but this is where we got to decide: is this a BVM? Is this a nasal cannula? Is this a non-rebreather? Right? It kind of differs on what we want to give. Now, it's touching on it quickly, but we'll go into more depth. Some patients will have chronic carbon dioxide retention. Now, that's typically COPD patients or COPDers. Okay. But it's because they have such damaged tissue, and I'll explain this a little deeper, a little further into the lecture, okay? But end of the day, they have low levels of oxygen that control their breathing. What happens is they end up having issues with CO2 retention. They air trap, okay? And because of this, they're unable to exchange that oxygen, and I'll explain a little bit more, like I said, as we get closer. This is a demographic, however, that we have to be very, very careful about how much oxygen we are actually administering, because too much oxygen for these people can actually become problematic. Moving on. So dyspnea, let's just go over some common causes. We'll talk about a few of these, or maybe all of them. But pulmonary edema, so fluid where it shouldn't be is edema, right? If you think about edematous ankles, when you see those typically older, in my experience, older ladies who are pretty sentient, or that's not the right word, stationary is probably a better way to describe it. They'll be sitting in a chair all day. They don't move very much. The blood pools in their ankles. They get really swollen and big. That's fluid, right? So that's edema. So pulmonary edema is fluid in our lungs that should not be there. The next one we'll talk about is hay fever. I'm not going to explain because once again we'll talk about these all. Pleural effusion, we have rubbing in the chest, obstruction of the airway, hyperventilation, right? So when people have anxiety or panic attacks, environmental or industrial exposures, drug overdoses, okay? All of those are potential. Now, end of the day, dyspneic, that's how you say it, not dyspneic, dyspneic. Dyspneic patients may have gas exchange obstructed, damaged alveoli, obstructed air passages, obstructed blood flow to the lungs, excessive fluid in the pleural space being the lungs themselves, okay? Or even in the chest around it, but digressing. All of these things, end of the day, will come back to the same problem. Poor oxygenation. With poor oxygenation comes poor perfusion. If there's poor perfusion, the body starts to fail because the cell's needs or the cellular demand is not being met. Little table, 16-2, if you want to follow along on your book. I will not be stopping on the table, so take the time, pause here if you want to read it, and we'll continue. Okay, now patients may also complain of chest tightness or air hunger. That's other type of descriptions of shortness of breath, right? Chest tightness, I just can't expand my chest. I'm just having a hard time getting a full breath. Or air hunger, where they're almost acting starved of oxygen. They're really gasping and trying to get that air in. Okay, now this is not uncommon with cardiopulmonary diseases, which there's a plethora of, and we're not going to talk about that. If you're curious, check out the cardio lecture. But things like CHF, congestive heart failure, right? That's a cardiopulmonary. It implicates both of them because one organ is failing. Now, one other thing to consider is chest pain, right? If someone breaks a rib, it's going to hurt to take that big breath. It's going to hurt to expand the chest, okay? So what the body will do at that point is, instead of using 3 to 4 really good breaths, says, I know what I'll do because it hurts to take one big breath. I'll just supplement that with 4 small breaths, right? So we start to get that rapid, shallow breathing, which, if we think about it, we are designed to live within a certain rate of breath, 12 to 20 breaths per minute to be textbook precise. Okay, so if we start to deviate from that, we start to have abnormal findings as well as abnormal reactions to it. So when it comes to the airways, you can have infections in the airways. Oh, before I get too far, remember the VQ mismatch, ventilation to perfusion mismatch, okay? I don't know why they chose Q. I didn't make the letters up, I just work here, okay? But ventilation to perfusion mismatch, the V/Q. Is it a ventilation issue? We are not getting air in. We have an issue with getting that air past the trachea or wherever it needs to be, okay, deeper into the chest. Or is it an issue of, well, they can bring air in, but for whatever reason, we can't exchange that gas. We can't use it. Okay, so keep that in mind. Now, anyway, infectious diseases may affect all parts of the airway. Some forms of obstruction will cause dyspnea. Okay, so if we have mucus and secretions, we have things that are taking up the space in our trachea, in our bronchi, that's narrowing those pipes. The narrower the pipe, the less air can go through, okay? Or is it something like swelling of soft tissue in the upper airway? Think of things like anaphylaxis. Someone has an anaphylactic reaction, so their face starts to swell up pretty aggressively, right? That's going to be something where they can't get air in. That's a V problem, okay? Or is it an impaired exchange of gases in the alveoli, right? Things like pulmonary emboli, which we'll talk about. But blood clots that are impeding blood circulation. They can get air in, they just can't utilize that air, okay? So there's several different avenues that you can see this. Okay, so we're gonna start diving into some conditions now. Some of these are gonna be pretty specific. We'll talk about the treatments after. I can't promise that I won't talk about them a bit before because I'm a little bit of a nerd for some of these things, but the first one we're gonna talk about is croup. Croup tends to be more of a children's disease. We see it at least more frequently in younger demographics. Think about cold and flu season in a school where we're packing, upwards of 400 or 500 kids into a small space. Diseases are going to travel pretty quickly through there, okay? But croup, inflammation and swelling of the pharynx, larynx, and trachea, right? So it's all upper airway swelling. Now, Hint, hint, wink, wink. You may see this again down the road on NRMT exams or exams in your own class, right? But the go-to identifying sign of croup for us is stridor and a seal bark cough. When these kids start to cough, it has a very specific sound that literally sounds like a seal barking, okay? If you're curious, look it up. It sounds pretty pretty close. Now, as far as treatments go, these kids respond really, really well to humidified oxygen. Okay, what that means is you're going to take your neb, but instead of putting albuterol in there, which I'm sure we'll touch on here in a bit, you're going to put nothing but normal saline in it. Okay, what that's going to do is that's going to hopefully kind of give those swollen structures a little bit of reprieve and let them relax a little bit. Okay, think about when you've been sick and you take a hot shower and the steam gets in your nose, right? Kind of feels better. It's the same idea. Another very common treatment, now this is depending on where you live, depending on the time of year. Another common treatment is going to be taking kids outside. If it's cool air, let them breathe in that cool air. If the entire upper airway is swollen and inflamed and just mad, right? That cold air is going to feel really, really good and almost act like an ice pack of sorts to that child's upper airway. Okay, so that's another very common treatment that we will use for croup, but croup is one that you will see. Now, another thing I want to emphasize with croup is that croup is a viral disease. Okay, it's one of those that you just got to be a little bit familiar with. It's not something they can just go on antibiotics for. Okay. Now, the reason I'm really bringing that up is to segue into our next condition, which is epiglottitis, okay? Epiglottitis is bacterial. Now, the big difference when it comes to viral versus bacterial really comes down to the severity of their fever, okay? Bacterial infections across the board, not just with epiglottitis and croup, but even pneumonia, okay, is another example. They tend to have higher fevers. And that's because our body recognizes, oh, this is a bug that we can kill. The hotter our temperature is, the less likely these little bacterium will survive. They'll denature. We'll be able to get over this sickness quickly. Okay, but and then viral tends to be a little bit lower. So think like your 100 to 101 type fevers. Think 102 to 103 for epiglottitis. Okay, but epiglottitis is a bacterial infection that causes inflammation of the epiglottis, right? Itis inflammation, so inflammation of the epiglottis there. The identifier for this one, these kids will typically be found in a tripoding position, okay, which as a reminder, that tripod position, they're going to be bent over, hands on the knees, trying to straighten up that airway. Think about it like when people get done running, right? They go for a hard run and they're winded and they're trying to catch their breath, and the natural instinct is to bend down, put your hands on your knees and open that airway up. Similar thing, but the big one here is these kids will drool. They will drool and drool and drool almost excessively, okay? Now when it comes to treatment of these kids, they're a little fickle, okay? We'll find out in the pediatric chapter down the road, but children's epiglottis is larger in a different shape than adult epiglottis, or the adult epiglottis, okay? Since it's bigger, it's going to be inflamed with epiglottitis, meaning it's going to get even bigger. So the problem with this is that if we mess with that kid's airway too much, we run the risk of that epiglottis sealing itself closed, which, if it's closed, because the epiglottis is designed to close the trachea, so when we swallow, we don't get things down in our lungs, you can kind of sense where this is going, right? The kids are going to have a hard time getting air in because that epiglottis is now impeding that trachea. So, as far as our treatment of this really go, just make them as comfortable as you can, give them oxygen, and just keep it kind of a low intensity. Bring the temperature of the room down just a little bit, right? Not physically, but as far as emotionally goes, right? Keep it calm because we don't want these kids screaming, we don't want them yelling, we don't want them panicking. Try to do your best to keep them calm. Oxygen and position comfortably. Okay, another fairly common childhood disease, RSV, Respiratory Syncytial Virus, RSV. Pretty common cause of illness in young children, okay? Very common with little ones. Causes infection in the lungs and the surrounding passages. Now for us, as far as identifiers go, it's tough. These kids look sick. They're gonna look like they have a flu or pneumonia or even, COVID, for lack of a better description, right? So a big thing for us is look for signs of dehydration. Now, depending on the age of the kid, that's gonna be easier said than done sometimes. With little kids, especially like babies who get RSV, you'll notice it in the fontanelle for that dehydration. They'll have a depressed fontanelle. Fontanelles are those soft spots that babies have on their head, okay? When that gets really depressed, that's a pretty good sign of dehydration. Okay, if we're talking more of like your school-aged kids, 4, 5, 6, 7 to about 9 or so, maybe even 10, look at their mouth, right? Are their lips dry? That's a really good indicator for us. Now, as far as treatments go, this is another one with humidified oxygen. Put that saline in a neb, run that, just try to give them some reprieve. But this time we're trying to hopefully break up any gook and gunk that might be in the lungs. Same thing, comparing it to taking a shower when you're sick, right? You take that big deep breath of steam, helps to break up all the gook that's in our lungs, okay? That's the idea. Now, I know it says common cause of illness in young children. Adults can also get RSV. My wife got a pretty nasty case of RSV a few years back from the homeless shelter. Right? If there's sick people congregating into the same space, illnesses tend to spread, okay? So do your best if you know it's RSV. I know they're not popular, but a mask is not a bad option. Just make sure you're not bringing these things home. One, you don't want to be sick, but your families as well, okay? Especially if you got little ones in the house. Now, kind of an extension or a progression of RSV is bronchiolitis, which if we break down the med term, bronchiole, the narrower portions of the anatomy in our chest, itis being inflammation, right? So bronchiolitis, inflammation of the bronchioles. Now, usually affects newborns and toddlers, once again, progressing from RSV, which is why RSV vaccinations are very, very common for younger kids, especially at the newborn age, okay? But the bronchioles will become inflamed. Inflammation leads to swelling, right? And at that point, they'll start to fill with mucus. So this becomes a Q problem because they can get the air in, but because of how tight those bronchioles are, they can't get to that exchange process. Okay, now once again, treatment, very straightforward. Oxygen therapy, frequently reassess. Now, as far as how much oxygen to give, that's gonna kind of come with experience. I would say let the patient's presentation guide you. Right? If they're obviously cyanotic and showing real signs of respiratory depression, consider putting the non-rebreather on. Now, if it's going to be something where the kid's sitting at, their skin looks okay, their activity is okay, probably going to be lethargic because they're sick, but they're sitting on an SpO2 of like 90, 92, we can maybe try a nasal cannula. One thing to consider though with kiddos is that they are not going to like that nasal cannula in their nose. Okay, so you got to make sure that they're not ripping that out of their face, okay, because they will try their darndest depending on the age. Okay, so pneumonia. Pneumonia tends to be a progression of most respiratory illnesses and ailments there, just because it tends to be a settling into the lungs. Now, when it comes to pneumonia, there's a few different types that people can get. They can have bacterials, they can have viral, they can even have fungal pneumonia. That's not an unheard of thing. But bacterial pneumonia, kind of like we talked about earlier with fevers, comes on quickly, results in a high fever, okay? Viral pneumonia tends to be more gradual and less severe. Not to say it can't be a life threat if it goes untreated, right? It can't be really problematic if it goes untreated. But for the most part, it just tends to be a little bit kinder on the progression there, okay? Now, the people who this really gets after, chronically ill folks. Think about your just generally unhealthy people, okay? This is where even living that kind of stationary lifestyle, when the people aren't moving, think your older folks in like a nursing home. Those people, because they're not moving as much and they have a higher likelihood of illness because one, they have weakened immune systems, two, nursing homes are crowding a bunch of older people together with compromised immune systems, right? That's the, increases the risk, okay? So, but the chronically ill, especially those with lung issues, have really high chances of progressing to pneumonia several times. Okay, now for us, assess temperature, provide airway support, supplemental oxygen. Not a lot we can do, and I hope you're noticing the trend when it comes to all of these is that when it comes to actually curing this disease or healing, quote unquote, these people, that's not really our game. That's not really our ballpark. That's going to be more for the doctors. Once again, our job is to recognize. Can we recognize, ooh, this is a life threat. We need to get them to a hospital sooner than later. That's going to be basically the description of what we need you to do. Okay. The next one, pertussis, otherwise known as whooping cough. Okay, so these people will cough, 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 right? So pertussis, whooping cough, airborne bacterial infection that mostly affects children younger than 6, okay? Because it's bacterial, they're gonna be feverish, probably a decent fever too, 102, 103, okay? Exhibit a whoop sound on inspiration after their coughing attacks. So just like I said, they're gonna cough, 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 you know, it's going to sound like they're gasping at something, right? Like if you think of any dramatic grandmother in TV shows or movies, right? Now, for us, a big thing, watch for dehydration, suction as needed. The suctioning is going to be not so much like fluid, it's going to be more phlegm. They're going to be coughing and hacking things out of their lungs, okay? Or even just, I've historically given them an emesis bag and just let them spit stuff out into it. It's not pretty, but that's kind of the game we signed up for. Okay, but dehydration is going to be a big one for just about all of these patients, just from a general well-being perspective. The next one, influenza type A. So 2009, we did have a pandemic of influenza type A. As far as, and I'm sure most people have had the flu at some point in their life and they know it sucks, right? But the symptoms include fever, cough, sore throat, muscle aches, headaches, fatigue. I've even seen nausea, vomiting on that list before, okay? May lead to pneumonia. Once again, remember, pneumonia is a progressive condition. It's going to be the condition that most respiratory tract ailments and illnesses can progress to if not treated well or not treated at all. Okay, and once again, dehydration is going to be a side effect of that, especially with nausea, vomiting, very potential. But a lot of the time when it comes to any of these kind of just general sick, people think about when you've been sick and how little you really want to drink. That's why things like soup are really good, right? They can cause that kind of passive hydration process there. Fun fact about influenza, after COVID, because everybody sheltered in place for so long, there was a strain of influenza that actually has disappeared. There have been no reported instances of it since the COVID shutdown, which is kind of an interesting byproduct of isolating in place. Not totally shocking, but interesting nonetheless. This is also something that people will vaccinate for. So, you know, depending on your department, they may encourage you to get a flu shot. You don't have to. Obviously, it's optional. Live your life. But not a bad thing if you're going to be going into sick people's houses all the time. Okay. Also, with the flu shot, don't be shocked if it doesn't work. Not so much that it's impossible, right? Get your vaccinations if that's what you see fit. But the flu shot is interesting because it only really works based on last year's strain. That's how they derived the next flu shot. It's like, oh, last year we had influenza type B going around. Let's make a type B vaccination. But the next year you have type A. So it's kind of right in there, right? You just never know what strain is going to be the most popular one of the year. Okay, COVID-19, SARS-CoV-2. Very similar virus to the common cold, very real thing. I saw a lot of people die of COVID. It does happen, it's a very real thing. But preferentially affects the elderly, right? If you think about it, they're living in close quarters. So those living in close quarters, which, you know, depending on the elderly people, dictates one thing or another. And then those who have weakened immune systems. They just have a higher likelihood, higher susceptibility of it. They have a weak immune system, the germs get in there, all of a sudden we're ill, right? So COVID, like, I mean, that could be anybody. All of these respiratory diseases, they will definitely have that same likelihood of transfer. But with COVID in particular, it was just, we saw so much of it and it spread so rapidly. And the reason being is because it's transmitted by aerosolized treatments or droplets and then airborne particles. So you breathe in the misting of somebody's sneeze or cough or whatever, you've already been introduced to the virus, okay? Now, another thing with COVID is that their respiratory deterioration can happen really quick. These people can go from breathing, talking happy to really struggling very, very quickly. One thing that, from my perspective that I saw that I found to be interesting is that these folks, when you see someone who's got a really low SpO2 reading, they're typically breathing pretty hard, they're trying to catch their breath, they're struggling, right? In 2020, 2021, we started noticing what we would call the happy hypoxics, quote unquote. These happy hypoxic folk, they would have a reading of literally like 75, and they would be like, I feel okay, I just feel sick. But as we know, that's a very drastic low number. So it was kind of an interesting finding when it comes to COVID. Not really sure what those 10-year, 5-year, 10-year studies will look like. Maybe here soon we will, as far as why it causes this deterioration. But keep that in mind. These people can go from, I'm sick to very, very sick very quickly. I've intubated several of these patients. I've seen a lot of these patients intubated. It happens. These people will deteriorate. So once again, not popular, but wear a mask. Wear your eyeglasses, especially when it's aerosolized type things. If you're going to be doing an aerosolizing procedure like a neb or above your scope intubation, dropping a supraglottic airway, that's where you need to get that HEPA filter on there, just because we want to make sure we're not just spreading these particles around, the 6x8 moving box moving down the road, okay? Okay, tuberculosis, TB. It's a bacterial infection, most often affecting the lungs, okay? Scary thing about TB is that it can remain inactive for years. It lives in your spinal column, your spinal canal, okay? Which is why when you go to most healthcare professions, they're going to have you do some sort of tuberculosis testing, okay? They're gonna put that little subcutaneous injection in your forearm. They're gonna have you come back 2 days later if that injection or that red spot they leave gets bigger or smaller, or bigger more so. There's a high likelihood you have TB, even if you're non-symptomatic, because once again, it can lay dormant for a while. But these patients will often complain of fever, coughing, fatigue, night sweats, weight loss, very common, right? Fever, coughing, fatigue, not uncommon as far as illnesses go. Night sweats, just because they're running fevers, okay? And then weight loss, because they don't want to eat. When people are sick, they don't like eating. It's just a hard thing for us to do. This is another one. This has an identifying symptom. It's not up here, identifying sign, and that is rust-colored sputum. They start having kind of a frothy around their mouth, like a frothy type of foam that has a rust kind of tint to it. It means that there's blood now seeping back into those alveoli. Not uncommon. Wear your gloves. This is definitely a wear gloves, eye protection, and N95s. At the agency I worked for, this was the only thing prior to COVID that we had to put an N95 on, just because there's such a high likelihood of bad outcomes. I believe, don't quote me on the exact years, but at some point, now 100 or 110 years ago or so, this killed, maybe more than that, this killed about 30% of the Earth's population under the age of 30. So TB is not to be trifled with. It is a very infectious disease. It is something you definitely want to get checked on, especially if you have an exposure, you have a known, like you're walking in and they know I have tuberculosis, put your mask on, because you definitely do not want TB. Okay, so I talked about edema earlier, fluid being where it shouldn't be. Now let's get into acute pulmonary edema. Now there are other things that can cause flash, quote unquote, flash pulmonary edema, which is just rapid fluid into the lungs, but we'll talk about those in a bit. But an acute pulmonary edema, the heart muscle cannot circulate blood properly. We tend to see this with congestive heart failure. Okay, they're having a hard time moving blood forward, pumping it forward out of the heart. Okay. So with that, if blood can't move forward, it's going to start backtracking. And if we think about the left side of the heart, it backtracks directly into our lungs. Okay, so we start to have an inundation of fluid in our lungs that should not be there. Okay, so like I said, usually the result of congestive heart failure, CHF. So if you have, which I'll come back to this, but if you have a patient who has a history of CHF and they're having difficulty breathing, this is definitely one of the things that should kind of activate the spidey senses a bit. In severe cases, you'll see a frothy pink sputum forming at the nose and mouth. Okay, so rust colored for TB, pink for pulmonary edema. Now this is also, all of these conditions are going to be lung sound worthy, right? Make sure you're listening to lung sounds. When I was out in the field and I had a breather patient, that was the first thing I was doing because it at least narrows things down, okay? If you're unfamiliar with what lung sounds, all of them are, you should definitely listen to as many as you can because it's hard to identify abnormal if you don't know what normal sounds like, okay? With edema, you're going to have rails or crackles, right? You're going to hear that fluid snap, crackle, popping in the lung bases. That should be an indicator. With the ones we've talked about prior, it tends to be more of like a rhonchorous or rhonchi sound, which is just kind of described as junk in the lungs. You hear the mucus. The way I would describe rhonchi, the way I have described rhonchi is think about that person that you know that's been smoking cigarettes forever and ever and ever, and every time they cough, you hear everything in their chest rattling at the same time. That tends to be what a rhonchi sounds like. So once again, make sure you're listening to lung sounds generally so you know what normal sounds like. And if you're confused about what these adverse lung sounds are, rails, crackles, rhonchi, wheezing, make sure you're watching videos, you're finding resources that will help guide you to what they sound like. Because once again, as far as identification goes, that's a huge, huge piece for us. And yeah, so this is a good description of that acute pulmonary edema. So if you look at the alveoli here, you can see the fluid starting to build up in the bottom, which is why we're going to hear that rails sound. When they take a breath, they have that inspiration. You're going to hear the air bubbles working their way through fluid to get through that alveoli to the capillary for gas exchange. Okay, that's why we hear the crackles there. COPD. Now, we kind of touched on earlier some demographics who we got to be careful oxygenating. This is the one, okay? COPD. So, the big precursor to COPD is smoking cigarettes. Just smoking in general, but cigarettes, obviously the most common ones. But slow process of dilation and disruption of airways and alveoli caused by chronic bronchial constriction, obstruction, and then tobacco smoke can create chronic bronchitis. So if you think about our alveoli, this is a good little picture. They look kind of grapes, if you think of like a nestling of grapes. Okay, so what happens in COPD, and I'll show you an image here soon, is if you think about a bundle of grapes versus a single grapefruit. If I was to ask you, take all of the skin off of a big bundle of grapes and lay them flat, how much room is that going to take up, right? Surface area. We need surface area. The more surface area we have, the better air exchange we have or gas exchange we have. Now compare that area of grape skins to the area of a single grapefruit skin. Those grape skins are going to take up a far greater amount of space than that single grapefruit, which is what starts to happen with COPD is that those alveoli start to get larger and larger and larger. And that's not including the mucus production that's going to start narrowing down their bronchi. Okay, but think about things like tobacco smoke, right? The tar that's associated with that, that's now in their lungs. So that's going to start taking up space in their bronchi as well. Okay. Now, when we talk about COPD is kind of what I call an umbrella diagnosis. It's an overarching, we're going to give it a description, this is COPD. Now, there's a couple of different things that fall under that COPD umbrella. Okay, the first one and the most common type of COPD is emphysema. Okay, so that when I was talking about the grapes to grapefruit, that's emphysema. That's more of that side of it. Okay, so loss of elastic material in the lungs. So there's no rebound. They kind of just become a set in stone shell of their size. So causes include inflamed airways and smoking. Right? So when people get swollen in general, which you think about breathing in anything that's just smoke, hot air, you're going to have that disruption in the lungs. Now, most patients with COPDs will also have elements of chronic bronchitis as well. So chronic bronchitis and emphysema both fall under that COPD umbrella. Okay, now chronic bronchitis, inflammation of the bronchi, right? Now notice in particular it says chronic, not to be confused with acute if we think about the acute pulmonary edema. Acute means it's a right now problem, it's showing up quickly. Chronic is more prolonged, like if someone has like a treatable cancer and they're getting treatments repeatedly, that's a chronic condition. So when we talk about chronic bronchitis, just because you had bronchitis once or twice does not mean you have COPD. But if you have bronchitis 3 to 6 months out of the year, or you get it every year for a month or two, that's where we start running into chronic bronchitis, okay? So this is that description I was showing you. We have our nice little grape set here, and then over time, as the smokers continue, or breathing in whatever, you start to see that expansion of the alveoli. And now, because they're getting so large, I know it's confusing because I was talking about surface area. This looks bigger, but there's less air being able to be passed through those alveoli. And on top of it, now we have that mucus buildup, because every time those airways get inflamed, our body produces mucus to protect that airway a little bit more. Well, if you're constantly inflaming it over and over and over and over, eventually you get to the point where you have obstruction because there's so much mucus that's essentially you've dammed off the road, or you've blocked off the road. They can't go forward anymore. Okay, so you're almost taking alveoli out of the game completely just based on the mucus production on top of your already lowered amount of gas exchanged. Okay, so you're going to hear a couple of different things here, right? So patients with pulmonary edema will have your wet lung sounds, okay? Your wet lung sounds being like their crackles, rails, maybe even rhonchi. COPD patients will have dry lung sounds, so think like wheezing, okay? Wouldn't be surprised if you heard some rhonchi in there as well, just because obviously going back to this picture, plenty of mucus in there, okay? Now COPD very, very frequently is confused with CHF, okay? They're both they're both lung issues in the end of the day. CHF obviously implicating the heart as well. But they're confused, and oftentimes patients will have a bit of both. It's not the craziest thing for people to have COPD and CHF. So you'll see an exacerbation on both sides of that. Now, end of the day, remember, we're treating our patient presentation, not just the lung sounds. Remember what I said. Lung sounds are a great clue. It's a good starting spot. You don't know everything until you ask the questions, but more so than that, read your patient. If you just rely on the technology you have, you're going to have a hard time. And don't fret, some of this comes with experience. It happens, but keep that in mind. Now this, once again, these are the demographic that we want to be very, very careful with how much oxygen we give them, because like I was describing earlier, CO2, carbon dioxide, is what stimulates our breath in our brainstem, okay? Well, these folk, because they start to have these mucus plugs, they start to do what we call air trapping, or they retain that CO2 in there. So their body, since it has a constant stream of CO2 circulating, kind of has to flip the script, and they go into what's called the hypoxic drive, okay? Where now, instead of reading how much CO2 is in their blood, they register how much oxygen they need, okay? So they're essentially guessing about when they have to take the trash out, right? Their guessing is when they have to get rid of the waste, because they're basing it on how much they have, okay? Which is why these folks tend to live. It's not uncommon to put an SpO2 probe on somebody who has COPD, who's on oxygen, who's on a cannula at 88%, 90%. That's not unheard of. In fact, when it comes to oxygenating these people, we do not want to get them above 92%. That is the number that we want to stay just about at, if not 91, okay? Right in that low 90s. We don't want to get to the normal 94 to 100, because then we're over-oxygenating these people, which there's a whole downstream discussion about what could happen from there with the release of what's called free radicals. We're not going to go into that, but that is the risk we run. So you got to be really careful with COPD patients. Make sure that we're not over-oxygenating them. Okay, so now we're going to move into kind of a different subset of conditions: asthma, hay fever, anaphylaxis. Now, each one of these is a result of allergic reaction to either inhaled, ingested, or injected substances. Now, caveated on asthma, we'll talk a little bit more about that. There's other things that can stimulate asthma responses. But as far as hay fever and anaphylaxis go, for sure, there's an allergen at play, okay? And in some cases, there's no identifiable allergen, okay? Think about just a spring day. You don't see the pollen that's wrecking your nose, right? Making it hard to breathe, not all the time anyway, okay? So you never really know what's out there that you breathe it in and you have an issue with it. I have family members who they are They're asthmatics, and they get triggered by things like candle scents. Okay, so you just never really know. Now, asthma, another way of describing asthma is what's known as acute bronchospasm. Okay, so if we think about the bronchi, right, and spasm, kind of like tightening up, think of like a muscle cramp type spasm. Okay, but now that's happening in our chest, so it's narrowing down those bronchi. Now on top of that, asthma as a condition also produces a bunch of mucus. Okay, they make what we call mucus plugs. Those mucus plugs will they'll close up. It's like a cork in a bottle. They'll start to close up those bronchi that are already swelling. Okay, so associated with excessive mucus production and swelling of the mucous membranes. The go-to telltale sign that we'll hear is wheezing. Okay, now depending on the asthmatic, it's not uncommon to walk into a house or a room with a patient and you can hear them wheezing without a stethoscope across the room. They can get that tight in the chest, okay? So that high-pitched, sing-songy wheezing sound is gonna be a good indicator for us of lower airway constriction, and then you should start thinking asthma from there, which once again, history solves mysteries. Ask the questions, do you have asthma? If the answer is yes, and you hear wheezing, pieces are starting to fall together. Now, asthma affects all ages, most prevalent in kids from 5 to 17, okay? Produces the characteristic wheezing that we're all kind of used to. I kind of talked about it. And back to the 5 to 17 thing, you can't really outgrow the disease, but as your body gets bigger, your body accommodates the swelling in there a little bit better. So it's not uncommon for people to have like asthma, and then as they get older, it doesn't really bother them. That was kind of my life. I was asthmatic as a kid, and then as I got older, it just stopped bothering me. Now, asthma attacks, as far as like that actual, the wheezing, and then they start getting to this air-starved type action, can be caused by allergic reactions, so food or allergens. But on top of that, things like emotional distress. If they're starting to get a little bit anxious, a little panicky, and they start breathing really, really fast, that's another way that they can kick off an asthma attack, okay? There's exercise-induced asthma. People start running and working too hard, and then they start to have the wheezing, things start to tighten up because they're breathing so hard. Okay, and the last one, respiratory infections. These are all things if they have a pre-existing condition of the things, asthma, a respiratory infection is just not gonna make it better, okay? Now, as far as hay fever is concerned, cold-like symptoms can start to present. So allergens, including pollen, dust mites, and pet dander, being amongst the big three that will kick off a hay fever type reaction. As far as what we're gonna do management-wise, not a lot. And I'll talk about the treatment for asthma. I'll do it right now. So albuterol. Remember, nebulized albuterol. If they have an MDI or a metered dose inhaler with albuterol, you can assist them in taking that. Remember, they're going to exhale all their air, and then as they take a breath in, you're going to give them one puff, one depression of that cartridge where they should be able to breathe it in. But moving back. So hay fever, there's not a lot we can do. Maybe oxygen, maybe, but it's going to be a cold-like presentation. As far as anaphylaxis is concerned, so anaphylaxis, if you're curious about the ins and outs of it, check out our anaphylaxis allergic reaction video, okay? But anaphylaxis, right, they have some sort of allergen that gets in, can cause massive facial swelling, that angioedema of the tongue, cheeks, neck area, okay? Becoming a V problem because they can't get the air in. Now, as far as our treatments go for anaphylaxis, at the basic scope, epi and oxygen, epinephrine, IM, and oxygen. And our dosing with epi, 0.3 milligrams for adults. For pediatrics, 0.15 milligrams. If they have an EpiPen, one, make sure it's theirs, make sure it's in date, not expired, okay? But the dose will be catered to adult or children, and we can assist them with that. It is now in your scope as well to draw up and administer epinephrine. And then antihistamines, things like Benadryl. Outside of your scope, at the ALS scope, we utilize Benadryl, and then usually like famotidine or Pepcid, as well as an H2 blocker. But I digress. That's anaphylaxis. If you're curious about anaphylaxis, check out that lecture. Okay, so pneumothorax. Talked about these when it comes to chest trauma, right? Traumatically induced pneumothoraxes. You can have spontaneous pneumothoraxes. Accumulation of air in the pleural space, right? So essentially it's a popped lung, right? There's a hole in the lung. All the air we're breathing into our chest is now bypassing, going through the lung, and is now going straight into the chest cavity, okay? Now, most often caused by trauma, but you can have medical conditions of spontaneous pneumothorax. Typically, the demographic you see is you're really tall, really slender, typically males. They do what we call paper bag syndrome. If you blow into a brown paper bag and then you smash it, it's going to run the risk of popping right? Same thing with a spontaneous pneumo. They take a big deep breath and they bump into something, and just because of their anatomy, they can actually pop that lung, okay? So other causes, if they have a lung infection, right, that tissue's already struggling, or they have weak lungs in general, it's pretty common for spontaneous pneumos to start showing up. The patient will become dyspneic, and this is where, once again, lung sounds are gonna help answer your question. Breath sounds, right? Listen to the lungs. If you hear sounds on one side, hear nothing on the other, that's a pretty good indicator that one lung is working and the other is not, okay? Another thing we can maybe pay attention to is chest rise. Do we have bilateral chest rise and fall? Because if one lung is popped, likely you're gonna have unilateral chest rise. One piece of the chest or one half of the chest is gonna be lying a little bit more still. Okay, so pleural effusion. Collection of fluid outside the lung, okay, compresses the lung, causes dyspnea. So we have fluid starting to show up around the lung. And typically how this happens is a lot of times with trauma, it can be medically induced, but the lungs are not anchored as well as they should be into the chest. And so at that point, the lungs will start to rub up against those pleural sacs, the pleura, will start to rub up against the chest wall, the interior side, creating irritation, which will bring fluid to the area the body's idea is hopefully to kind of lubricate that so it's not rubbing against each other and catching, but can stem from irritation, infection, CHF, or even cancer. Now with these folks, the biggest thing, upright positioning is going to really help them out, right? Think about gravity. If someone's laying on their back and their whole lung is touching their chest wall, they're going to have a hard time expanding because it's going to be uncomfortable. But if they sit them up, gravity is going to pull that lung down. And that's most of your breather patients. You want to position them in an upright seated position just for ease of breathing, okay? And then depending, where we see demographics of morbidly obese, or bariatric demographic, their own weight of their tissue can actually make breathing harder. So make sure you sit them up. That's a very, very important thing to do. Potentially oxygen for treatment. Going back to PEs, not PEs, pneumothoraxes. Treatment is going to be oxygen for you guys. And definitely get ALS en route, because ALS can perform needle decompressions to, hopefully the idea is to recreate the vacuum of the chest so that lung can expand, but I digress. Okay, so obstructions of the airway. Now, patient with dyspnea may have a mechanical obstruction. When we say mechanical obstruction, think about them choking on something so they didn't chew their food very good, or even like the tongue. The tongue, fun fact, is the most common blockage in an unconscious person. So in unconscious patients, obstruction may be caused by aspiration of vomit or the tongue blocking the airway, right? So aspirating means they're breathing something, not air, into their lungs, so they puke. It's kind of the thing when, if you're a delinquent like me, you've had friends who you go out and you party and they start throwing up, you lay them on their side, because if they lay on their back and they puke, they run the risk of choking on it. That's aspiration, okay? But the tongue, the relaxed tongue will fall back into the throat. Now, if the patient was eating before they had that difficulty breathing, consider foreign body. Foreign body or upper airway obstruction, the sound that we're going to hear associated with that is going to be stridor, okay? Remember, you're going to hear that stridor up in the throat. It's going to have that same sing-songy kind of wheezing sound, okay? So make sure you're at least looking into that. Now this image right here shows the tongue falling back there. So the food, we have a food occlusion on the top, bottom one we have the tongue here, which is why with the tongue we got to be really, really specific with OPAs, oropharyngeal adjuncts, to help hold that tongue from going back into the throat or that pharynx area. Okay, continuing on the train, we have PEs, pulmonary emboli, okay, so, or embolus. Pulmonary embolism, if you want to get particular, but a blood clot that circulates through the venous system. So differences, we have thrombus, and we have an embolus, right? A thrombus is a stationary clot. An embolus is a moving clot. Now, not to say those two things can't become interchangeable, not so much in the verbiage, but a thrombus can become an embolus, which it can become a thrombus, which can become an embolus, and so on and so forth as it gets stuck and moves and gets stuck and moves, okay? But when we talk about a pulmonary embolism, this clot has now landed in the lung, okay, which is going to essentially drop a log over the river of blood flow, right? We're going to dam up that blood flow. Well, if we have no blood moving forward, it's not getting oxygenated, okay? If it's not getting oxygenated, that's not really helpful or useful for our body when it comes to perfusion, okay? But this will significantly decrease blood flow, and then if large enough, can cause sudden death. It will literally, lack of a better term, internally choke them. They're going to be unable to move blood and oxygenate blood because of the blockage of circulation, okay? Which if you want to see some crazy pictures, you can Google pulmonary embolism clots, and they have pulled clots out of people's vasculature that will literally map out their vasculature. It's pretty crazy. They can get really large. Now moving on, signs and symptoms include dyspnea, tachycardia, tachypnea. Hypoxia will vary, right, depending on the severity of the clot. But cyanosis, the blue around their mouth, pretty good sign, or in their fingernails. Acute chest pain or hemoptysis, coughing up blood. Now, when I was in medic school, the go-to textbook symptom signs that you'll see when it comes to a PE is normal lung sounds, right? Because there's nothing blocking the air passages themselves, it's the circulation. But then you'll see a low SpO2. So difficulty breathing, clear lung sounds, low SpO2, and then when it says acute chest pain, that was described to me as pinpoint chest pain. They're going to tell you it hurts right here. Now that's the textbook answers. That's what the NREMT is likely expecting you to understand so you can put that together in a scenario-based question. In real life, I've seen PEs present a number of ways. I've had one gal in particular comes to my mind. She was complaining of shoulder pain. That was her only complaint. Took it in nice and easy. All of her SpO2 was fine. Lung sounds were clear. Nothing that was really triggering me. And then when we got in, or I got the report back on her, she had a PE. So reality differs a little bit from our textbooks from time to time, but if you're familiar with the textbook answer, if you see it, you're gonna know very, very quickly. If it's a weird presentation, trust your gut, do what you gotta do. End of the day, probably just gonna need to oxygenate them and get them to where they need to be, i.e. a hospital, as soon as you can. And then if we talk about demographics that have a high likelihood of acquiring PEs, think about people who live stagnant lifestyles, right? So once again, your older folks who sit in their chair, people who've been on prolonged trips, so they've been sitting in a car or on a plane for 8, 9, 10, 12 plus hours, right? They have a high likelihood. People who have had recent surgeries have a high likelihood of PEs. Just because if you think about it, their body's trying to form clots so that it can heal, which if a clot gets loose and starts moving through the venous system, it's going to go right back to the right atria, right ventricle, shoots right out to the lung, okay? Another demographic is going to be women on oral contraceptives. Oral contraceptives can throw off the body's regulation systems, and it's not uncommon for them to present with clots. My wife had a patient one time, it was a PE patient. She ended up, I think she was a younger gal, I want to say in her upper teens, but she ended up essentially having 16 blood clots in her lungs, was what the final tally count was on that. And that was all because she had swapped her oral contraceptive and had been taking different ones over the course of 2 weeks, and that just all culminated into affecting her clotting cascade. Okay, moving on to the next one, hyperventilation. They're breathing too fast. Okay, so they overbreathe to the point that arterial carbon dioxide falls below normal. Okay, a portion of this is the pons on the brainstem, the little kind of Adam's apple looking guy on the brainstem, taking over and basically putting you in a fight or flight. Your pons is saying, you're not doing a good job breathing, I'm going to take over, which is where panic attacks typically start. Now, hyperventilation can be an indicator of a life-threatening illness. Are they breathing rapidly and shallow for a reason, right? Is there something blocking that their body's like, we got to supplement quality for quantity, let's just get more going, okay? Not a crazy thing. That's why treat your patient, not just your vitals. Get good histories, make sure you're being thorough. The body may also be trying to compensate for acidosis, right? Because remember, CO2 in our body is an acid. So by breathing CO2 off, we're lowering our pH. Now you can overdo it. You can definitely overbreathe and hyperventilate to the point that they become alkaline almost, or their body pH starts to drop, or rise rather. But the body, and then buildup of excess acid in blood or body tissues, right? So even things like very, very common diabetics, DKA, right? Those ketones are also acids, but so the body will start to respond with the Cheyne-Stokes respiration, Kussmaul respirations, fast, rapid, deep breaths to try and get rid of the acid. But the problem with DKA is it's not a CO2 problem, it's a blood problem, right? So the body's just trying to regulate and figure out what's going on. So you might see that from time to time as well. Now, can result in alkalosis, like I said, so buildup of excess base in our body fluids. We breathed off too much of our CO2, which, fun fact, if you've ever had a panic attack or seen someone have a panic attack, not an uncommon symptom for their hands and feet to start to cramp up kind of like this pretty aggressively. We call that carpopedal spasming, and that's because they're breathing off all of their CO2 so fast that they're becoming alkaline. Okay, but can cause symptoms of a panic attack. So anxiety, dizziness, numbness, and then here's that tingling or painful spasms of the hand and feet. Not uncommon for people to start cramping up in the hands and feet. Very uncomfortable for them. I used to spend time just trying to open their hands up to give them some reprieve as we're calming them down, just one less stimulation to overcome. So you might see that from time to time. Hyperventilation though, make sure you're deep diving into why they're hyperventilating, and not just, you're having a panic attack, which is very, very common for providers to do. Don't be so assumptive, especially if you're new to this game, because you want to make sure your experience guides you. And if you don't have the experience, be thorough, do a good assessment, don't miss things. Environmental exposures. Now, it really depends on where you live and what kind of system you live in. If you're in a more rural area, you might see things like pesticides, but cleaning solutions, chemicals, chlorine, other gases can be released. Depending on the gas, you're going to have an adverse response. For example, chlorine gas. Chlorine gas, if you took a big old sniffer of that guy, that's when you would have that flash pulmonary edema. Essentially, if you get enough chlorine gas in your system, you will drown in your own fluids before anyone can do anything about it, because that fluid will build up so fast, okay? But carbon monoxide, that's going to be one of the most commonly seen gas exposures on our end. Carbon monoxide is odorless, it's highly poisonous, and produced by fuel burning appliances and smoke. So house fires, or you may even have the suicidal patients who are doing a suicide attempt with their car exhaust. Okay, that's all potential CO problems. And carbon monoxide can be, well, first off, don't put yourself at risk, right? If you sense that there's a gas, or if you show up to a house, for example, as a call, and there's a family of 4 outside, they're all complaining of dizziness, nausea, dyspnea. Maybe we don't go in there. Maybe we get hazmat involved and have them go check it out, because if everyone's complaining of the same thing, it's likely the location they were at. When it comes to CO, remember also that their SpO2 readings are going to be normal. They might even be batting 100%. And the reason you see that is because nature inherently is kind of lazy. Okay? When we talk about the oxygen we breathe, O2, there's 2 oxygen molecules. Well, monoxide, 1 oxygen molecule. So your hemoglobin on your red blood cells will look across into that alveoli and say, ooh, I can either carry 2 oxygen, or I can carry that guy, which only has 1, and that seems way easier. So it'll grab that and it'll bind. So We will typically describe CO as having a higher affinity to our hemoglobin, or vice versa, our hemoglobin having a higher affinity to our carbon monoxide molecules, because it's easier. So once again, don't be tricked by that SpO2. Read your patient. If they're breathing hard and they're struggling, you just pulled them out of a burning building, they've had smoke inhalation, right? Don't just be like, well, your SpO2 is 100%, you're probably fine. No, right? Double check. Depending on where you're at, you may have some equipment that can help actually read CO. One device we used to use, a lot of the fire departments around us use, is what's known as the RAD 50 or RAD 47. And the RAD essentially will read oxygen, SpO2, and pulse, but it'll also give you a CO reading. So really just depends on where you're at and what kind of equipment you have. But it's a great tool, okay? Now realistically, is there much we can do about it? No. But if it's something like CO, we can just oxygenate them. Let's get fresh air in there. Let's get oxygen circulating, not just that carbon monoxide. Okay, so scene size up, nothing crazy. PPE, make sure you're checking your surroundings. ABCs, right? We've been focusing on airway and breathing throughout this, as well as some circulation. So remember, everything needs to stay intact there. I really like this image. When it comes to listening to lung sounds, these are great locations. I will say, first off, if you can get directly to skin, get to skin. That way you don't have the rubbing of the clothes. But listen to the back. If you're not listening to the back, you're likely missing things. Think about how people carry tissue. Think about demographics. Women tend to have more tissue on the front of their body, right, i.e. breast tissue, as opposed to men. So you might hear lung sounds easier in males from the chest, but end of the day, listen to their back. The back is going to be the easiest, most encompassing location. If you don't have access, once again, the chest will work, but do your due diligence and make sure you're attempting to get really good lung sounds there. History is going to be big. Remember CHF, COPD. You can ask questions. Are you a smoker? How long? How many packs a day? Not that you're realistically going to know, like, oh, they smoke 3 packs a day. They probably have COPD this bad, right? You're not going to know. But by knowing that they're a smoker, you can kind of put pieces together. Oh, do you have COPD? Right? Or if you see someone who's a smoker and they have a low SpO2 and they're on a cannula, right? Make sure you're checking. Also, just for the room, if you see someone smoking a cigarette who has a nasal cannula on, maybe take the cigarette from them. They're not going to love it, but it's better than being, lit on fire. Secondary, not a lot, right? If you're going to get a hands-on, it's going to be a little bit tougher. If you're curious about what these slides say, go through the book. Now let's talk about our care, our treatments, okay? Supplemental oxygen is going to be a really, really big one. That's going to be our go-to when it comes to respiratory conditions, because the respiratory tract needs it, right? Our respiratory system needs it. So some patients may need CPAP or BVM, bag valve mask, right? So keep that in mind. Patients who have an MDI, right? So a meter dose inhaler, they're going to need that, or they might have a nebulizer. Utilize your stuff. Or consult medical control, right? You can always make a phone call to medical control and say, hey, this is what's going on in front of me. What should my treatment be? And they're going to help you. Okay. Now, some of them, if you have a known asthmatic, it's like, I have an inhaler right here. Maybe that's one of those we don't call medical control because we know the answer should be right in front of you. So make sure you know the treatments to the best of your ability. Make sure there's no contraindications. Okay, and then most medications used to relax muscles that surround the air passages in the lungs. Like albuterol, for example, is a bronchodilator. It opens up those bronchi and helps people take a big breath. Now there are some side effects, nothing comes free, right? Some side effects of inhalers, you might see an increased pulse rate, they might get nervous, they may even start to twitch a little bit, get muscle tremors. They're side effects, make sure they're aware. When it comes to true contraindications to albuterol, the only one that's ever been really noted is marked tachycardia, meaning that they're ticking along at 140, 150, right, consistently, and then we give them this and it just makes that number go up. But end of the day, right, think about if the body's not perfusing and not oxygenating its blood very well, it's going to try and circulate the blood it does have faster. Okay, so it's not uncommon, or even anxiety and panic, right? These people are probably going to be a little bit scared, a little freaked out. Well, when we're freaked out and scared, our heart rate goes up, right? So don't put too much stock in that, but make sure you know your local protocols that might differ. Okay, so Our upper and lower airway infections, our treatment of choice, administer humidified oxygen, right? So I haven't heard of any agencies that carry specifically humidified oxygen. I could be wrong, they probably exist. But for the MacGyver situation, saline in a neb, that will open that up, that will humidify that air. Do not attempt to suction the airway or place an OPA, right? Especially if we're talking epiglottitis, because you're gonna make that epiglottis really mad, and once again, we run the risk of that thing dropping. Prompt transport. For acute pulmonary edema, 100% oxygen, suction as needed, position comfortably, provide CPAP if indicated, right? Continuous positive airway pressure. That is in the BLS basic scope. So wherever your department is, make sure you're familiar. They're gonna have more than likely a BLS specific CPAP, usually just plugs onto the oxygen and you just open it up to 15 and away it goes. But depending on your system, you may have like a ventilator that has settings, and that's probably out of your wheelhouse. So just know what you're allowed to do and transport promptly. For COPD, if they have an inhaler, give them an inhaler, right? Watch for side effects of overuse, so that marked, or that tachycardia, right? Maybe the twitching. Position them comfortably, i.e. sitting up, and then transport promptly. For asthma, be prepared to suction. These people will be, because if they start coughing, coughing produces things, right? They can have productive coughs or dry coughs, but if they have stuff in their lungs, likely gonna have productive coughs. So you may need to suction those mucus plugs as they cough them out. If the patient has an inhaler, you can assist them with that as long as it's prescribed to them, not expired, so on and so forth. As far as aggressive airway management goes, right, we can set up our own neb, we can get non-rebreathers going. You can nebulize through a non-rebreather, okay? Just make sure, typically when we nebulize people, it's anywhere from 6 to 8 liters per minute on a normal T nebulizer. If you're gonna use a non-rebreather to nebulize, make sure you're sitting at that 10 to 15 mark, okay? But you can give high flow oxygen with a non-rebreather and nebulize at the same time. Keep that in mind. For hay fever, not a lot we're gonna do for it. Unlikely they're gonna need emergency treatment. Does not mean they're not gonna call you for this, but not much we can really do for them. Take them to a hospital, okay? But anaphylaxis, whatever the offending agent is, make sure you remove it. So if it's like they're allergic to their detergent, maybe get them different clothes. If they get stung by a bee, scrape that out with like a credit card or something rigid. Never tweezers, so we're not squeezing that back in there. Maintain the airway, transport rapidly, and remember epinephrine for anaphylaxis. That's your indicator. There are no contraindications for epi in cases of anaphylaxis, or no absolute rather, contraindications for anaphylaxis or cardiac arrest. So 0.3 milligrams IM for adults, 0.15 milligrams IM for pediatrics, okay? For the spontaneous pneumo, give them oxygen, transport them promptly, monitor them, right? These people are likely going to deteriorate pretty quickly, okay? Pleural effusion, fluid removal must be done in hospital. Not much we can do, right? They need to go in and pull that fluid out of the chest. So give them oxygen, transport them promptly. Hopefully you guys are seeing a bit of a trend here. Obstruction of the airway, partial obstruction, provides supplemental oxygen, transport, right? Remember, if it's partial obstruction, and they can still breathe, they can still talk, we're not gonna fiddle with that too much, okay? We don't wanna make the situation worse by getting involved too aggressively. So just give them oxygen, make them as comfortable as possible. If it's gonna be a complete obstruction, they are choking on something, clear the obstruction. So if they're conscious when you get there, the Heimlich maneuver, abdominal thrusts, okay? Until they lose consciousness, at which point you will start CPR. Once you start CPR, you're gonna hopefully force that offending object out, okay? Give them oxygen, and then both of them transport rapidly. For PEs, oxygen is mandatory, right? Remember, this is a blood circulation problem, so we wanna make sure we're circulating as much available oxygen as we can into these people. Position them comfortably, once again, sitting probably up. If hemoptysis is present, they're coughing up blood, clear that airway immediately, suction, 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 okay? And then transport. Hyperventilation, so complete your primary assessment and gather your history. Is there a reason this is going on? They have known anxiety conditions and something stressful just happened. The most common example scenario you'll see is Usually a teenage girl, my boyfriend just broke up with me and I can't, they start doing that anxiety panic. It happens. Don't have them breathe into a paper bag. That's counterproductive, right? We want to make sure we're oxygenating. If they're just rebreathing CO2, yeah, it might balance out whatever alkaline they have, but they still don't have oxygen circulating, okay? Reassure the patient, provide oxygen, transport promptly. I've also seen with hyperventilation a few different techniques, especially if it's anxiety or panic related. I stole this a little bit from like a military thing I was saying, but box breathing. Have them inhale, and I would draw a box with my finger. Inhale for 4 seconds, hold for 4 seconds, exhale for 4 seconds, hold for 4 seconds, inhale, hold, exhale, hold, all for that 4-second count. So make sure you're 1, 2, 3, 4. Hold, 1, 2, 3, 4. Exhale, 1, 2, 3, 4. Hold, 2, 3, 4. I've seen that calm people down pretty effectively. Another method that I never really thought about until I saw it is if someone's having an anxiety attack or they're panicking, have them read something out loud, okay? And they're gonna tell you they can't. Encourage them that they can. Tell me what this says. By getting them to read, it makes them slow down just kind of passively and naturally. That's another method I've seen work. There's also what's known as grounding techniques. I have not had much success with those, but it's basically appealing to the 5 senses. What's something you see? What's something you can feel? What's something you can smell? Right? What's something you can hear? Okay? Maybe don't go with taste, just because that's kind of a weird one. Or maybe have them, what's your favorite food? Imagine how that tastes, right? But asking them the questions is a good way to ground them. Like I said, have not had much success, but if you have and it works for you, more power to you. For industrial exposure, one, make sure they're not contaminated, right? We need to decon those patients. If it's something where it's a fluid on them, make sure you're irrigating the area with saline aggressively for about 20 minutes. If it's like a powder, let's brush that off of them as much as we possibly can, just because we don't know what that really is. And then saline, flush that out. Okay, but treat with oxygen, adjuncts as needed, right? MPA, OPA, and suction based on their presentation, depending on what they got into. Also, it may do you some good too. There are several apps out there and there's books. I'm old, I had a book that would tell you the placards and what these gas placards would mean. You know, if you look at like a gas truck, they have the little red diamond that has a flame on it, tells you it's flammable. There are placards for gases as well. Not a bad idea to have maybe something like that on you as well. For foreign body aspiration, right? They've breathed something in, clear the airway if they're choking, provide oxygen transport. Tracheostomy dysfunction, so trach tubes, when people have that tube in their throat, connects the trachea straight through the skin, bypassing the nose and mouth. I've seen it before with things like throat cancer where they have to cut pieces of their vocal cords out. You're gonna see these a lot. These get kind of gross from time to time. They'll fill with mucus. And that's one thing we get called to suction those out, or like sometimes they can become dislodged, right? But if there's, but anyway, position them comfortably, suction to clear if there's an obstruction, and give them oxygen. You can give them oxygen directly onto the, that trach tube itself. Most of medicine is fairly universally sized, so your BVM should work for that as well. For asthma, blow by oxygen. So what that is essentially, the descriptions in the book is to punch a hole through a cup and then put an oxygen tubing through there and to basically hold that, crank it to high and then hold that by their face so they ambiently breathe it. Not a lot of ambulances that I've been on have carried cups, so we would just do a non-rebreather, open that up all the way, same kind of process. Use the MDI. Remember, you can nebulize albuterol yourself, okay? And then for cystic fibrosis, it's a genetic disorder that affects the lungs and digestive system. Typically, they're pretty fluid-filled. Suction, oxygenate as needed. This is one where we got to be careful, even things like CPAP, where we would typically use that for fluid-based problems. Got to be kind of careful because their lung development is a little bit suspect there. Last thing I really want to talk about, we didn't really touch on it here, but just things you're going to want to know for the NREMT. Let's say we have a patient who's breathing 6 to 8 times a minute. right? We obviously know 12 to 20 is the perfect number. Well, we need to get them back to a more normal rate. So this is where we're going to use our BVM, and we're going to do what's called assisted ventilation. So you're going to create a good seal on the face if the patient's conscious, which hopefully they are. If they're not, makes it a little easier. But if they're conscious, coach them through it, because put yourself in their shoes. If you're not breathing very good, the last thing you want is someone putting something on your face, because you're probably going to panic a little bit, right? But as they take a breath, you're going to give them a little puff of air, help them complete that breath. And then over the course of the next 5 to 10 breaths, you want to slowly titrate that rate until you're delivering one breath every 5 to 6 seconds, okay, if it's an adult, about every 3 seconds if we're talking pediatrics, okay? But you want to get them back to that point where they're within that normal range. And our EMT will also tell you, anyone breathing faster than 28 times a minute will get that same assisted ventilation, right? Because at that point, they're breathing so fast, they're actually not oxygenating very well, okay? So make sure you're double checking on that. If they're 28 or greater, you can still do that assisted ventilation and try and coach them to calming down so that you can get them back to that one breath every 5 to 6 seconds. All right, well, that is our respiratory lecture. Hopefully you guys enjoyed it. Hopefully you learned something, and we'll see you next time.